Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we are now going to talk about something called urothelial cell carcinoma. Sometimes this is also called transitional cell carcinoma, abbreviated as TCC. So be on the lookout for either one of these. This is the most common renal malignancy in the urinary tract system, and it most commonly is going to affect the bladder itself. However, it's important to keep in mind that it can actually affect some other structures, such as the renal pelvis, the renal calyces, the ureter, or the urethra, but typically a classic board style question is going to involve the bladder here. Now, it's important to keep in mind that I said this is a common malignancy, because in the next video, we're going to talk about squamous cell carcinoma of the bladder, which is fairly rare relative to this actual pathology. So when we think about the things that can cause this presentation in a patient, there's a really good memory aid that starts with PSAC, which we will remember as PSAC to help us remember some of the causes. The P in our memory aid stands for phenacetin. So phenacetin is a formerly used fever reducer. However, it's actually been pulled from the market in both the United States and in Canada. And so it's less likely to be the answer or the presenting cause of a patient on a current question stem. However, it is a medication that was formerly used that can lead to this type of cancer in a patient. Now, the key one I want you to remember here is smoking tobacco. This is the #1 risk factor. And so if you're going to remember one, that's the one I want you to know. It's also important to note that this is a dose-dependent effect. That is to say that the more you smoke, the higher your risk of this cancer forming is going to be. If you don't smoke very much, your risk is not going to be as elevated as somebody who's smoking significant. So that is to say, somebody with a 5-pack year smoking history has a less risk of developing this cancer from smoking versus somebody who has a 30-pack year smoking history. So that's the S in our memory aid. Next, moving on to the A in our memory aid, we're going to have the aromatic amines. And so sometimes they'll give you the name of a couple of these. The two main ones I see tested are going to be either aniline di or benzidine. And so keep this in mind if you're seated in test questions, right? If they write out the name, know that these are aromatic compounds, and these can actually increase a patient's risk of developing transitional cell carcinoma. And then finally, to round out our memory aid, we have cyclophosphamide. So cyclophosphamide is a alkylating agent that is actually used to treat tumors or other types of cancers. And in addition to increasing a patient's risk for transitional cell carcinoma, it's also classically associated with the adverse side effect of hemorrhagic cystitis. And so that's an important correlation to keep as well with this medication cyclophosphamide. Now, moving on to our presentation here, there are a variety of different ways that they will present this to you in a question stem. So there are classic ones that we talk about, such as painless hematuria. Remember in a previous video, I said to associate painless hematuria or painless red blood cells in the urine with a malignancy, right? Until proven otherwise, painless we associate with malignancy. Painful, we're going to start by making the association with nephrolithiasis or kidney stones just because that's the most likely. However, there are a few other things that can cause painful hematuria as well. But you see painless, the first thing I want you to do is think about a malignancy in the urinary system. Now, some other key findings that I want you to be familiar with include urinary frequency, urgency, and dysuria. Again, these are things that we could expect to see in a lot of different urinary pathologies. These are some classic symptoms of a urinary tract infection. But again, we're using all of our clues here. We're not just using the urgency, the dysuria. If we see that in addition to painless hematuria, that should draw our attention from, oh, this is classic UTI to, oh, this patient might actually have a malignancy going on because that would explain their painless hematuria. Again, in clinical practice, this varies greatly, right? How a patient presents and their symptoms. But for the purposes of board questions, they're often going to give you what's deemed the classic presentation. So the painless hematuria classically is going to show up in a board question as a malignancy in the urinary system. When we consider our diagnostics here, we're going to see a lot of the routine tests that we're getting with most of our urinary problems, right? So we have the urinalysis, some imaging, and some histopathology. On the urinalysis, we're going to expect to see some hematuria, right? I said a classic presentation for these patients is to complain of blood in their urine, typically a painless presentation. If we got a urinalysis, we'd expect to see that blood. Now, we won't see red blood cell casts. And why is this important to remember? Well, the reason this is important to remember is because if we do see red blood cell casts, what types of pathologies are we thinking of? That's right. Red blood cell casts are typically seen in glomerular diseases, such as things like glomerulonephritis. We're not likely to see this in something that's affecting the bladder. It's not high enough in the urinary tract system. The bladder is considered our lower urinary tract, but our red blood cell casts are likely to come from our upper urinary tract, so in the nephrons, in the kidney itself. And that's why in these patients, we don't typically expect to see red blood cell casts. If we do, we need to expand our differential a little bit to include things like a glomerulonephritis or various other glomerular diseases. Now, if we have these patients who come in and we suspect there might be a bladder cancer or cancer involvement in the urinary system, what do we need to do to confirm this diagnosis? Well, the best thing to actually do is to get a biopsy. And you do this by getting a cystoscopy, which is essentially where you stick a tube through your urethra so that you can see inside the bladder, and then you take a biopsy at that time. So a cystoscopy plus a biopsy to actually see, does this patient have cancer? Now, you can also consider doing a CT urography. And a CT urography is going to give you a better view of the entire urinary tract system. And so this can also be a very useful imaging modality. So you want to do both of these if you can, but keep in mind differences that CT urography sees the whole urinary system versus the cystoscopy gives you direct visualization of the bladder and allows you to take a biopsy at the same time. Now, when we move on to our management options here, there's a couple key things I want you to keep in mind. And the primary thing I want you to note from the question is, does it involve smooth muscle invasion? That is to say, has the cancer spread from the superficial surfaces in the bladder to the muscle surrounding it? Because this is going to change our treatment option. Now, when it comes to treating a bladder carcinoma, you're going to do one of two things. If there is no smooth muscle involvement, there's no invasion into the smooth muscle, you're going to do something called a transurethral resection of the bladder tumor. That is, you go through the urethra, you remove the tumor. However, if it has spread, if there is invasion of the smooth muscle, you're going to have to do a bigger procedure, which is to do a radical cystectomy, which is to actually remove the bladder and remove the tumor altogether. So really the distinguishing point here is the tumor invasive or not? If it's invaded the smooth muscle, then we need to remove the whole thing. If it hasn't invaded the smooth muscle, we can do a little bit more of a localized treatment with the transurethral resection of the bladder tumor. However, keep in mind, I said that the bladder is the most common place for this tumor to occur, but it's not the only place. So what happens if we're dealing with a carcinoma in a different location in the urinary system? Well, now you're looking at a variety of different options that can include nephroureterectomy, which is to remove the kidney as well as the ureters, plus or minus chemotherapy. This is going to be a little bit more complex in terms of how we make these decisions. It's really not expected for you to know this at this level. But the key point I want to make here is if it's in the bladder, which is the most common place, if it's invasive, we're doing a radical cystectomy. If it's non-invasive, we're doing a transurethral resection. So a very classic vignette for this type of condition is going to involve a 75-year-old patient who comes in with a 30-pack year smoking history, indicating they've smoked a lot throughout their life. They are complaining of new onset blood in their urine that has been present for 2 to 3 weeks. They're very concerned by this. However, they aren't having any other symptoms. They aren't having any pain with their symptoms. They're just concerned about this new onset of blood in the urine. After getting the history and physical exam, the clinician decides to get a urinalysis, which confirms the presence of hematuria. However, the question stem also indicates to you there are no red blood cell casts. The question could then ask you, what would you like to do next? For which we would want to get a biopsy and some additional imaging. They could give you even more information and give you that imaging and then ask you what would be the treatment option. And again, this is where it depends. Is it invasive or is it non-invasive? So that's a very classic patient presentation, right? It's often a smoking history because that's the #1 risk factor for this particular cancer. So just quickly in summary, to review, we have urothelial carcinoma of the bladder, sometimes also called transitional cell carcinoma or TCC. This is due to a variety of different things that we're going to remember with our memory aid PSAC because it's very memorable. That's going to be phenacetin, smoking tobacco, which is the #1 risk factor, aromatic amines, and cyclophosphamide. When we think about the presentation here, it can present in a variety of different ways, but we think about our classic symptoms for urinary pathologies. That's going to include things like frequency, urgency, dysuria, and hematuria. Recall, think of malignancy when you see painless hematuria, because at this level, that's most likely to be the patient's condition. Our workup is going to include our pretty standard things, our urinalysis, our imaging, and even some histopathology. Now, one thing I actually want to draw our attention to before we wrap up this video is the histopathology here. See, we have dysplastic urothelium and a papillary tumor with a fibrovascular core. So this condensed group of cells, a bunch of purple cells, are dysplastic. They're not in their kind of typical spaced out presentation like you're seeing over here on this image. Additionally, we have the papillary tumor with its fibrovascular core. So you can appreciate this is a very vascular system. There's a lot of blood cells going through here. And the papillary portion is referring to the type of tumor that's actually present. And that indicates how the tumor actually grows. So if you draw your attention to the bottom here, we can have two things happen. We can have invasive tumors that actually grow down into the tissue itself, get deeper and deeper. These are more likely to invade the smooth muscle. Or we can have something called a papillary tumor, which is a less aggressive form of the tumor that actually grows as little appendages in the bladder itself. And so that's what this image is showing over here, a papillary tumor with a fibrovascular core. And finally, when we're talking about management options here, depends on invasion, right? Are we dealing with this type of tumor or this type of tumor? That's going to help us determine, are we using a transurethral resection of the bladder or are we doing a radical cystectomy? Now, this cancer can occur outside of the bladder, and if it does, treatment is going to get a little bit more complicated in terms of what do we do, but we're going to consider things like removing the kidney and the ureters, plus or minus chemotherapy as well.